Well, good afternoon, everyone, and welcome back from lunch. My name is Michael Perry, and I'll be moderating this session's panel discussion. This morning, we heard about the elements that go into a framework. Now the committee will have the opportunity to hear from potential framework end users. The committee has prepared a series of questions for the panelists to discuss during the first hour or so of this discussion. Once we've cycled through those questions, the committee will have an opportunity to ask additional questions that emerged over the course of the discussion. Before we begin, I'd like to introduce our four panelists. On the end is Lisa Pivec, Senior Director of Public Health for the Cherokee Nation National Health Services, and is currently the Principal Investigator for several funding agreements with the Centers for Disease Control and Prevention. Ms. Pivec served as the Accreditation Coordinator for Cherokee Nation's participation in the Public Health Accreditation Board Tribal Standards Beta Test, and now oversees the Cherokee Nation's application for accreditation to the Public Health Accreditation Board. She is responsible for operations within the Healthy Nation Program, Male Seminary Recreation Center, Women, Infants, and Children WIC Program, and the Breast and Cervical Cancer Early Detection Program. Seated to Lisa's left and the audience's right, we have Dr. Thomas Ricketts III. Dr. Ricketts is a professor of health policy and management and social medicine at the University of North Carolina, Chapel Hill. He has a joint appointment at the Gilling School of Global Public Health and the School of Medicine. From 1988 to 2008, Dr. Ricketts was the director of the North Carolina Rural Health Research Program, which seeks to address problems in rural healthcare delivery through a variety of avenues, including basic research, policy relevant analyses, and dissemination. Between 2001 and 2010, he served as the chair of the Scientific Advisory Committee to the America's Healthy Rankings. Dr. Ricketts works actively in health workforce policy making and research. He has developed national and state policies governing the distribution of health resources and healthcare practitioners, including the development of a new approach to designing primary care and dental health professional shortage in medically underserved areas. Next, we have Dr. Paul Simon. Dr. Simon is the Director of the Division of Chronic Disease and Injury Prevention at the Los Angeles County Department of Public Health, and he's an adjunct professor in the Department of Epidemiology at the UCLA Fielding School of Public Health. He is board certified in pediatrics and preventive medicine. In 1992, Dr. Simon completed a 2-year epidemiology fellowship with the Epidemic Intelligence Service at the CDC, and then served as a medical epidemiologist in CDC's Division of HIV/AIDS Prevention, assigned to the Los Angeles County HIV Epidemiology Program from 1992 to 1998. From 1998 to 2006, he was the director of the Office of Health Assessment and Epidemiology in LA County Department of Public Health. In his current position, he oversees Tobacco Control and Prevention Program, Nutrition and Physical Activity Program, Cardiovascular and School Health Program, Policies for Livable Active Communities and Environments, PLACE Program, Injury and Violence Prevention Program, and the Office of Senior Health. And then finally, to my right is Dr. Joseph Thompson. Dr. Thompson's work is centered at the intersection of clinical care, public health, and health policy. He's the director of the Arkansas Center for Health Improvement, a pediatrician and professor at the University of Arkansas for Medical Sciences. Dr. Thompson also served as the Arkansas Surgeon General from 2005 to 2014 and was director of the Robert Wood Johnson Foundation Center to Prevent Childhood Obesity. Arkansas was the first state to legislatively mandate a comprehensive statewide effort to curb childhood obesity. Included in the mandate was the annual assessment of BMI in public schools. Dr. Thompson and the ACHI were at the forefront of developing and implementing this project. They continue to maintain what was the first and largest collection of child BMI data in the world, with more than 500,000 records annually. I welcome all of our panelists here today. To begin, I'd like to hear about obesity prevalence and the trends currently being assessed in your respective domains. Dr. Thompson, would you like to expand what was touched upon in your introduction?
Sure, thank you. And thanks to the Academy and the committee for the invitation. We have been collecting now BMIs annually in our schools. This will be our 12th year. Over a decade ago, both the Institute of Medicine and the Academy of Pediatrics recommended that every parent have and know their child's BMI percentile for weight status. In our state, and I think across most states, very few parents had ever heard of a BMI at that point in time, so we chose to use the school-based setting as a mechanism to address that. Over those 10 years, we have had, as you mentioned, a linked cohort each year of kids have their BMIs assessed. We now do it every other year in even-based years, so kindergarten, 2nd, 4th, 6th, 8th, and 10th grades. We have seen a flattening, as has been reported in the national data, in the increase in obese children. We've also been able to characterize the differences between different races, different genders, and different age groups because of the census aspect of our assessment. It's not a sample, it's actually a census of every child in every school in those grades. And we have not seen a reduction in the childhood obesity rates within our state. And I think one of the things that I would comment on that was alluded to, if not highlighted this morning, we have great regional variations in this epidemic nationwide, and every one of the national surveys really gives, with the exception of the Youth Risk Behavior Survey, which, as was attested to, is self-reported, they're all kind of a national average of what the prevalence is of the epidemic. When we did our first assessment, and this is in part why we got on the front page of the Wall Street Journal and other, we found that our children in Arkansas were 1/3 heavier than the national estimates were, which both could be a lag factor. Those data come out 2 to 3 years later. But I also think more importantly over time, I think we have a regional factor that the South, because of its preponderance of risk and exposure, is having a more significant burden from the epidemic than probably the nation as a whole or some other regions.
Thank you. Paul?
Well, I'd also like to thank the committee and the Academy for the invitation. I think the theme that you may hear on this panel that differs quite a bit from what was presented earlier this morning is that at the local level, we really need much larger numbers to do quality surveillance. And in Los Angeles County, we have about 10 million residents, about 2.5 million children, a land area of 4,000 square miles. We have 88 cities and 81 school districts, and in order for us to get the needed data down to the community level, we need much, much larger numbers than what was presented this morning. And we've used two primary data sources that have been very helpful. One is a school-based system in California. The state requires that all 5th, 7th, and 9th graders in public schools be fitness tested each spring, and one of the measures is body composition. And the schools are given several options to measure that, but the vast majority do it with measured height and weight. That gives us about 300,000 records every year to include in the analysis. The other data source that's been very valuable for us has been the WIC database. And here again, while it was mentioned this morning, that's mostly low income. In fact, it is lower income families and children. In LA County, the reach of WIC is about 60% of all 0 to 4-year-olds. So it's very significant. Again, the numbers are very large, about several 100,000 records each year. We've seen a leveling both in school-age kids and in younger 3 and 4-year-olds beginning around 2005, and in the last couple of years, the beginnings of a very slight decline. Just to highlight what Joe said, the incredible variation is seen not only in different regions of the country, but even within a single jurisdiction. So in our worst impacted communities, generally these are very low income communities, we see childhood obesity rates among school-age kids around 30 to 35%. At the other extreme, generally in the most affluent communities, the obesity rates are down around 5 or 6%. So if we didn't have access to this sort of surveillance data, we would really be in the dark, and we wouldn't be able to target, focus our efforts the way we need to.
Thank you. Tom?
I do build on what Dr. Thompson said about the relevance of data that is collected nationally and even at the state level to localities, is that we really work hard to make the national surveys very precise, and we heard a lot about that effort this morning, and it is all commendable. But that, as we strive for perfection at the national level, we tend to create an enemy of the good at the state level, and then that in turn is the enemy of the local. Because as we refine and make more precise these national estimates, we tend to lose the variability and the reality of what is happening at the local level. So the kind of really creating a uniform system sometimes creates really militates against understanding what is the reality at the local level. That's been said many, many times when I'm dealing on a panel that's talking about rural health, as we talk about, local variation is just not reflected in national statistics, and it never can be in one sense. But there is also a fact that we are not making use of locally built up data sets, as Dr. Simon was talking about, in that, and that some other states are creating, that we could be building a series of really focused local assessments and survey materials and calculations that could, let's say, move from place to place over time. The NHANES, those vans and trucks that go around and do the measurements, really that's a real intense clustering process that is intended to generate a national estimate. But it might be useful for them also to create intense local, say rolling local assessments and evaluations that would give something of a snapshot, not intended to be a national sample, but intended to give a look at what the variability is as opposed to the central tendency. Because that's where the problems really occur, is where there are outliers that really need intensive and customized interventions, as opposed to a larger, let's say, a national mean where we have a general trend which stimulates some local work. But when the local work reacts to a national trend, you really don't have the sense that you're working against an achievable goal or achievable or from an achievable baseline. So I think the really an understanding of the local versus national, the local versus general, the dynamic of the data, and then the need to apply solutions at the local level really says that we might be wanting to refine more ways in which we understand local conditions and the variance and the really conditions that occur where there are people who are actually working to reduce obesity rates.
Thank you, Lisa.
OCO, thank you for having me here today. And I don't have to tell you that probably when you know that when it comes to American Indian Alaska Natives, the childhood obesity prevalence data does not exist. And especially when you get to the tribal level. What we have been doing, the YRBS within the Cherokee Nation for the last several years, mostly with our own resources, and our prevalence rate is 28%. And that struck me as I looked at the national averages and to think that there's a population living within the United States that this is this high. And then when we do our own BMI collection, which we've been doing for about 5 years, sampling in 52 different schools within the Cherokee Nation, we have a 37% overweight obesity rate. That's extremely high. And if you look at different tribes across the nation, you will see that it varies, but it is definitely higher than the national average. For us, the reason that it's so important for us to have local level data is that our particular area, Cherokee Nation, is located within the eastern part of Oklahoma. We take up about a third of the state. We are not on a reservation. There are no reservations in Oklahoma. We have about 100,000 Cherokee citizens living throughout that area. And so for us, we have limited resources and we have to figure out where to put those resources. So we are trying to look at obesity on a very local level, county-based level. And so for us, that is a huge challenge. And the national level estimates do us a little good, but the local level, trying to find something that's convenient and repeatable for us to do, and something that is efficient and cost-effective for us to maintain and to do in our local areas.
Well, it sounds like there's a consensus from among the users here that the data that's going to be most useful for them is going to be data that is local. That the national data are helpful, but what's most important to you folks is figuring out what's going on in your own communities, your own backyards. I wonder if you could each take a little bit of time to talk about what the barriers are to getting data that are reliable, valid, and useful to you on the level in which it's most helpful to you. Paul, do you want to tackle that question first about the barriers?
Sure. Happy to. Our two systems that I described, the school-based system and the WIC system, are immensely valuable, but both I would describe as very precarious. On the school side, we've had the classic situation where two public sectors aren't talking to each other, aren't cooperating. We're having actually trouble each year getting the data from the California Department of Education because of their interpretation of a federal law called FERPA, and I'm forgetting what FERPA stands for, but it's sort of the equivalent of HIPAA. And their attorneys currently, not in the past, but currently are interpreting it very strictly. And for us to get the data, they're only allowing it to be used for, quote, research, and they don't view surveillance as being research. So I have staff that are proposing these very elaborate research protocols just for me personally, so I can get the data for surveillance. On the WIC side, we have this, again, immensely valuable data set because of funding from an organization in California called First Five, and it exists because of a tobacco tax. The money is earmarked for early childhood programs, and our county First Five Commission has decided to prioritize obesity prevention, and they're providing funding to our WIC agencies to collect the data, but their funding is diminishing, and so I'm not confident that we're going to continue to have that data source. So just to summarize, it's amazing to me when you consider how important this problem is, yet how fragile our surveillance at the local is for it when you compare it with our surveillance for other things, communicable diseases, for example, and a number of other areas where we do surveillance where we have much more stable infrastructure.
Tom, do you want to address the issue of barriers and challenges to assessing the trends perhaps in rural areas or different geographic regions of the country?
Yeah, and Dr. Simon mentioned an application of FERPA. Our General Assembly has just restricted or passed a bill that restricts access to student information, which includes the same type of restraints. And I think this is the result of a model bill that I think you'll see replicated in other states. So the concern with privacy is creating something of a toxic environment for people who want to do this kind of work when we're talking about children's health. Another aspect of this is that there actually are a lot of data, and people are very creative about capturing data at the local level to do programs or to stimulate programs and make things happen at the community level. What is a problem is that the local perception of obesity or a target may not match that of a national perception or a national standard. And there probably needs to be better communication from those who interpret and disseminate national standards as how they can be applied and interpreted in the local context. This is I guess you would call this cultural adaptation, or just local understanding, or just getting it right so somebody can do something about it. And this is, you'd be surprised at how injurious this is when you see conflicts in the, quote, literature, and how much they diminish the ability of local policymakers and decision makers to come to a conclusion. Because when they see, as was presented earlier, dueling headlines about obesity, then that negates the problem. It doesn't say that that all things are right and that this is still a problem. It says we don't know, so don't do anything about it. That messaging needs to be interpreted in a proactive manner, so that people can understand that there will be debates, but then here is what you can depend upon that is relevant to your locality. So standards of research are one thing, but standards of local interpretation are another. And building the argument so that you can create a sense of urgency or create a sense of identity with a local problem is really something we need to train people in, as well as how to disseminate and structure the diffusion of information. It's really teaching folks how to locally understand the conflicts in information that they have so that they can act on it.
Lisa, you want to tackle assessing trends, assessing the problems and the challenges you find?
Oh, yes, definitely can address that. How much time do I have? No, just kidding. A couple of things especially important in Indian country that I need to point out, and one is that the public health infrastructure to do any kind of surveillance and monitoring does not exist in Indian country, and the dollars are not there to do that. The monies that come to tribes for health care go to direct care and delivery, and still there's not enough money for that. So those of us that are working on public health infrastructure are doing so on dollars that we have in cooperative agreements from CDC or dollars that we have received through our tribal governments. With YRBS, the challenge is this year we almost didn't get enough schools to agree to have weighted data, and that's going to continue to be a problem for us. We work with the state of Oklahoma and pull a sample, and what we do is actually do the sample that's within the Cherokee Nation for the state. And we have many schools that are tired. They just almost wouldn't let us in this year, and we worked really hard to do that, so we're concerned about that for next year. And what we've experienced at the local level with YRBS is that when we present the information to our decision makers, they want to know what schools were involved. And is my school in there? Because, of course, this is not their problem. It's probably someone else's problem. And we, of course, can't do that. We, of course, can't give them that information. And then actual measurement, which we do BMIs in the school. We have actually lost our funding at the tribal level for doing that because we've not been able to demonstrate a quick enough change in childhood obesity over 3 years. And so some of the decision makers have decided that that money is not working fast enough to decrease childhood obesity. Most of those folks are used to seeing something in which, like, if somebody's diagnosed with hepatitis C and we can give them a drug and that makes a difference immediately within 3 years. Obviously, it's an understanding that childhood obesity is going to take a long time to reverse. And the last point is, when I see CDC tout that they gave $10 million to Indian country to work on chronic disease programs, it excites me, but it also very much frustrates me because they have to understand that there's no local infrastructure to measure or to surveil and monitor what is being done to show that those chronic disease evidence-based interventions are working. And I think I represent Cherokee Nation on the CDC Tribal Advisory Committee, and I'll certainly be making that point next week as well. In Spokane, we are meeting next week.
Thanks, Lisa. Joe, you want to give your perspective?
Sure, quickly. I agree with several of the comments. I think the FERPA issue is a real issue if you're doing school-based work. I think it could be carved out in a certain way under interpretation if there was kind of a legal guidance for how local educational lawyers could value that. The biggest barrier, I think, is true commitment and prioritization of this as an issue. I think we have intellectual commitment by most that we have a problem, but we either don't achieve or we undermine the commitment when it comes to putting resources to implement surveillance programs and to follow on with interventions. And I'll tie back to the national data in a way that has not been alluded to so far. When the national data comes out with a headline that says we've reversed it nationwide, and we are still losing the battle locally, then suddenly the commitment gets eroded locally, and you even go farther, deeper into the abyss. So with the lack of local data to say, no, we're not reversing this, or no, we're not actually the same as the national average, any tribe, any community, any state that is below average, that commitment gets eroded by the national dialogue. So I think that's a conversation at the national level that should be taken into account. And finally, I think there is a movement to redefine the negative obesity into the positive of healthy living. I'm okay with that, but let's not lose the threat of obesity as a true, health and financial and economic and security threat to our nation's future, because this is now defined as a clinical condition. It isn't defined as an epidemic. It is defined as something that's measurable. Let's not make it too touchy-feely when it is a real risk.
Okay, I'd like to shift gears a little bit. This morning we heard about frameworks for how we would take a look at the kinds of data that are going to be useful in assessing prevalence and trends in obesity. And I'd like to get the perspective from each of you on if you were going to design a framework, what would be the components of it? Tom, would you mind starting us off on that?
Let me think about a framework in a slightly different way, and think about a framework for what are the links of specific policy actions you take to the result in, say, reducing obesity. In other words, if you don't have a walkable street escape in your city, how many people does it kill? And if you don't change the way in which you do school lunches, how many kids are going to grow up and die prematurely because of that? I'm speaking of a framework of argument, a framework of rhetoric that is scientifically based, but also resonates within a policy framework. I understand that we're actually in a fairly simple thing. You have height, weight, and let's say waist circumference, but then translating that up into lives lost, productivity lost, into problems with behavior in a place. We've got to make sure that those are connected, but somehow we also have to be able to have the logic of interventions understood. And that those interventions are not just isolated into programs, specific programs, but they're interactive. So I love the program logics of the programs and processes that are put in place, but they assume a larger understanding that they assume that a larger logic has been satisfied, and that is that people do understand what the consequences of this is as an illness and as a condition, not just as a clinical condition, not just as a socially more desirable state that people are way less. So I think frameworks of problems that policymakers can understand, linked to frameworks of interventions that we know and have some evidence work that are also interconnected is the kind of framework that I'd like to see.
Thank you. Lisa?
I couldn't agree with you more on that particular issue. Those are the type of frameworks that we need. We need to be able to show the linkage between those policy and infrastructure development issues within our community. We need to be able to show our decision makers what that means when we decide to not implement a certain policy, or that we decide not to put a sidewalk in a particular area, or we restrict bike lanes and so on throughout our particular communities. It's something that I agree that there's not enough commitment at our local level, because I think they don't understand the overall and long-term impact of childhood obesity and what is going to happen. And for us being able to relate that back to what we're seeing on an everyday basis. And we have a unique organization in that we have a public health program, but we also deliver care to 90,000 patients a month, direct care. The majority of those visits are people coming in with diabetes and hypertension. And being able to link all of this back in real time for our decision makers to say, here's the problem now that you're seeing both within our children, and you're seeing a problem within the adult population. These are the reasons that we need to do this, and this is the linkages. These are the policy decisions that you need to make, and when you don't make those, this is the result down the road for us.
Joe?
So I'm going to put my very pragmatic hat on, so therefore it's not going to meld very well with some of the academic models that were proposed this morning. But I would advocate for a framework which looked at something around the frame of the progression of obesity risk. And I say that we started out 12 years ago, as many others did, after us, in the school-based setting, because it was a controlled environment and the policy levers were clear and you could kind of see what you could do to affect the environment. But then we discovered, hey, most of the kids are obese when they come to kindergarten that are going to be obese. So we moved upstream into the 0 to 5, and then we actually proved that it was mother's weight gain and the baby's birth weight. So there is a progression of risk that we can pretty much track in early childhood, and then the obesity leads to metabolic instability, and then it leads to specific clinical indicators, and it leads to real things that we're paying for in clinics and hospitals and in mortality. And I think if you have that framework of progression of risk of obesity, number one, and then you are intentional on why you're assessing, is it the incidence or is it the prevalence that you're wanting to assess? And then is it that you're doing an intervention to see whether you actually had an impact on the prevalence or the incidence? Or is it a public health perspective of I'm doing surveillance to see how bad this risk is, but I'm really not trying to change anything? That's the policy framework where you're going to be able to engage with policymakers and give them something to do. If it's in the translational hypothesis generating space, that's valuable, but that's not actionable in the policy making role.
So if I'm understanding correctly, the framework is about evaluating the collection, analysis, interpretation, and dissemination of data. It's a little bit different than evaluating evaluating the effects of interventions. Those are related, but they're two slightly different things. So I'm going to focus on the former. And I think one really good resource is actually the CDC in an MMWR, Morbidity Mortality Weekly Report, has put out an issue on evaluating surveillance systems. And it's very straightforward, simple, intuitive. It's because it was designed originally for communicable disease surveillance. It may not be 100% applicable, but I think there are lots of really good insights there that could be helpful to the committee. In terms of data interpretation, I just want to make a specific point. I would hope you comment on the importance of distinguishing between absolute percentages and relative percentages, because I think we get into trouble, and particularly with the headlines, when we talk about relative percentages. If, a 50% drop when it went from 2% down to 1%. So providing guidance on those sorts of things, I think. Very importantly, surveillance has to be linked to public health action. And so, unlike research, which may or may not, and the time frame in which action happens is much more prolonged. And so I would hope there'd be some guidance about the importance, in fact, the imperative that these sorts of surveillance data need to be linked with policy and programmatic action.
Okay, you folks have made a really strong case for looking at the big perspective and the motivation for doing this and putting it in a context that's meaningful to local communities. But I wonder if we can really get into the weeds, and if I can ask you this question, how would you actually measure what's going on in terms of the weight status of the individuals who make up your communities and have that tracked over time? So this morning we heard, for example, how the Haynes does it, but then we also heard about the self-report methods in the youth survey. What would be the methods that you would recommend that are the minimum threshold in order to be able to assess whether there's any kind of change in the population that you're concerned with? Tom, you want to start?
Well, I mean, here's where creativity takes a hold. You have to have mechanisms that talk about the weight of the population, the weight of the local population, and how much they have lost or intend to lose over time. And maybe you take a big tanker full of animal fat and dump it on the ground to show what the sum of overweight in a school is or something. I mean, something that dramatizes this. This is not specific measurements. This is creativity with interpreting the process. You're not going to have an algorithm that motivates people. That motivates only a very small percentage people who think symbolically. But we have to think really in a perceptual way, and in a way in which people can relate to themselves. If we're talking about change of behavior or change of policy, it has to be confronted in something of a physical and an emotional way. I'm sorry that's not, we're in the hallowed halls, the National Academies of Science, but at some point we have to learn how to communicate in a way in which people, it does change their beliefs and perception in a way that is not necessarily numerical or cognate, but it is something that is felt.
Okay, so
maybe that sounds like a cop-out, but
let me follow up on that. So suppose we take a bag of pig fat and we put it in front of each person, and it's 30 pounds, and that's the 30 pounds heavier than it was in a generation ago. That makes an important point. But how do we know it's 30 pounds now heavier than it was before? What's the basis of the data for that? That's what the question I think I'm trying to get at.
Why do you have to know it's 30 pounds? Why can't it be 28 or to 32? I ride a bicycle a lot, and I'm overweight. And while going up a hill, somebody asked me how much do you weigh? And I said, well, what I weighed at the time. And he said, that's probably an extra bag of sacrete. And when I thought about carrying an extra bag of sacrete up the hill, over the next 2 weeks, I lost 10 of the pounds of that 30-pound bag of sacrete. So, I mean, I had a need to visualize what it was in order to do something about it. And I know this maybe is touchy-feely or something, but it's the way things get done, and it's the way people interpret it if we're talking about just folks as opposed to rational calculators.
Lisa, your perspective?
Yeah, I'd kind of like you to ask the question again. I'm trying to clarify what we're actually talking about.
Okay, how are you going to know in your community whether there's been a change in the prevalence of obesity or the trend?
Right, well, and I think that's going to be...
If you're going to know that, it needs to be based on some kind of measurement or assessment.
Right.
And how would you do that measurement or assessment? What would be the framework that would tell you this is an appropriate way to do that measurement and this is not a good way to do that measurement?
For historically for us, the only reliable information that we have right now to look back on would be our healthcare data that we have, that we collect on every visit, and we monitor those trends over time. However, that's limited in the patients the people in our population that don't come in to see the physician, and it's limited in that is it accurate? Sometimes we don't know for sure. We've done a lot of field work in which we did actually BMIs on adults, voluntary, and we offered incentives to come in and have your BMI done every 6 months, and we did that for 5 years and watched the trends over 5 years, and amazingly enough, we had a huge population of people coming in because they got an incentive to come in, and many were repeat people for the most part. We had a lot of the same people, and while that was a good source of information for us, it was also a good community awareness tool at the same time. Obviously, the school-based method, I have mixed feelings about collecting BMIs at the school. It's the best that we have right now. But for us, we're going to be able to see some changes, hopefully, on that. And one of the points that somebody made a while back about the will becoming reduced after you see a headline that says childhood obesity drops by 50%. Well, let's take the reverse of that and have someone within our tribe say, childhood obesity across the nation has dropped 50%, yet ours keeps flat and keeps going up. Our programs must not be working, therefore let's quit funding all of them. So for us, the measuring piece of it, this is a difficult question for me as far as historically and looking at what's going to happen in the future. I mean, I'd love to have a framework that we could put in that would be, clean, that would work, but I'm just not sure what it looks like.
Okay. Joe, you've kind of piloted the approach to having a framework to some extent with the schools in Arkansas.
So I think there's several important points. First is that the BMI itself is just a screening tool. So it has inherent error on both over and under diagnosis of accuracy in the fact that it is a screening tool and that you do need some follow-on exam to ascertain truth. If you start from that premise, any collection process that adds error to your screening, which increases your false positives and your false negatives and undermines the credibility of the surveillance process. So we made a fairly early decision not to actually go to actual measurements and to try to stay away from self-reported indices where we knew the reports would be biased in a single direction and undermine the effectiveness and accuracy of the screening. We did put in, and we actually developed a protocol. It's interesting, I'll briefly share. So we had a researcher at our academic medical center who was excited about the opportunity of measuring every child in the state until we realized that that meant that we were going to be measuring almost 500,000 kids in 1,500 schools with no resources. And she wanted an academic grade shoreboard stadiometer in every school, which cost $1,000 a piece. We ended up building a stadiometer in my garage and proving that it, with a carpenter square, if used appropriately, could validly get a height on a kid if we did 2 successive measurements. Interestingly, the researcher got 2 shoreboards bought for Central High School, but they got thrown away over the summer because the janitor did not know what they were. So I think you have to scale your, I would advocate for measurement, accurate measurement, but I would advocate for it to be feasible in terms of scope, scale, and cost within a range of accepted error, which you have to have a method and a validation of that and some attention over time to the fidelity of the process that you're putting in place. So you can do it. We did it in 1 year with no resources. We figured out a method to assess 500,000 kids in 1,300 schools. Going forward, the health department subsequently did basically a mini NHANES across the state where they went into homes and in communities and assessed not just height and weight for obesity, but a broad range, found actually that half of Arkansas adults have hypertension, which the estimates, again, were 30 to 35%. So, when you actually do physical measurements, you get a much more accurate assessment of what the risk burden is. I think looking forward, there are opportunities to more efficiently garner the electronic health record when people touch a clinic, to actually have that be networked as part of the information exchange. I think it will not happen unless there are financial incentives put in place that make payment be contingent upon that participation of the clinical community. And if there's a receiver for that information to do the interpretation or some sampling method by which they're going to use that new electronic resource as a way to reach out and collect data that's already been measured but hasn't yet been submitted.
I agree with a lot of those points. I want an objective measure because I want to be able to compare across populations and over time. I think we have to think about cost, and as Tom had said, I don't think we should have the perfect be the enemy of the good. I mean, in the ideal world, I'd love a DEXA scan on all kids, but that's not really realistic. I am comfortable with height and weight measured. We've not felt comfortable in LA County with self-reported or parent-reported. Before this morning, I might have said I would trust the adolescent self-reported, but based on what I heard today, I think there also we would want measurements. I guess I'll go ahead and stop there.
Can I just, I think an important point for the committee to clearly delineate is when it's consecutive cross-sectional assessments versus when it's a longitudinal cohort assessment and when and why you would use either. I think there's not common knowledge or even common discussion about which of those two is superior to the other under what circumstances, or which might more likely lead you to a type 1 or a type 2 error in the assessment of whether change has happened. So I want to highlight that. I mean, a cohort is great for some things, great for most things. A cross-sectional consecutive assessment gets you part of the way, but doesn't really tell you whether you're moving people to a healthier position individually.
The one other point I had forgotten is just that surveillance, in my experience, is sort of messy, and the data aren't nearly as clean generally as in well-designed research studies. And I've been impressed, even though there aren't really strong quality controls in our schools for measured height and weight, the results seem to make sense to us when you compare our results with other places. I think, again, it doesn't have to be research-grade quality to be useful as surveillance.
Joe, I'd like to pick up on one point that you made, and that is the future of electronic health records, and particularly with PCORI now in the Affordable Care Act, and there's a lot of encouragement for the development of networks of data across communities, across states. And I'm wondering, and if what you and the rest of the panel would think about, what's the potential there for using that as a method related to surveillance?
So with my public health hat on, I'm always concerned about using the medical care system to do surveillance, because you clearly have a user community and a non-user community. Mm-hmm. So when I allude to the electronic health record, I'm not limiting its presence to the clinical setting. I think our schools could and should have an electronic health record. Have to work through the FERPA issues, but to have a population-based mechanism to access and input electronic health information. In the adult population, it's going to be a little more difficult. I think you have some employer organizations that are more willing to take on their population of employees with health risk assessments, and if they are tied to an electronic health record, that can then be a mechanism to actually counterweight for non-users in an adult kind of surveillance mechanism, potentially. But I think as we come in, I mean, every one of us in here probably has at least one electronic device that they've looked at in the last 15 minutes. And so, you know, how we use that electronic capacity in a way that gets us valuable information, I think, is an important future. I will caveat that, though, by saying our education department is moving to an electronic calculation of BMI in the schools that when we did a validation against, it had about a 5% error rate, and I think probably the issue is they're tying to the year age of the child instead of the month age of the child when they calculate BMI. So some recommendations of the fidelity of the application of the CD, whatever the equation is you're going to use for, currently we use the CDC's BMI percentile calculator. It ties to the month age of the child, not the year age of the child. And I think those recommendations should be incorporated for the precision of whatever recommendation this committee comes out with.
Anybody else want to weigh in?
Also, there is a problem with some of the electronic surveillance systems, is that they need to be really dynamic. That is, that it's amazing the persistence of a number in a record. When taken at any given time, it becomes that somehow it just stays there and doesn't change. So it's very important in children that you have a dynamic series of those data. And then what is hilarious is a company called Epic and Cerner and people, they don't really like dynamic data, and which is just totally bizarre to me. But it is those situations in adults when you have a spike of weight change or weight loss that are most important. But for children, it is a pattern and then a risk score, and that is really dependent upon dynamic longitudinal data. So their surveillance has, at the individual level, has to recognize that its need for not just diagnosis but assessment over time, and that is one thing that those systems are really having a hard time dealing with.
Let me just build on Tom, because I think this is one area the committee could come out with a strong set of clear guidance, which is for the electronic health record companies to do it right. They're really not doing it right at the present time, whether it's having a date tied to when the assessment was, which is what Tom's talking about, or even incorporating the BMI algorithm for kids' percentiles. Many of them don't do that even. So I think because that's the future, getting it right now will make it be easier for us to achieve the surveillance goals that we share.
Okay, before we turn it over to questions from the committee, I'd like to just go through our panel one last time with the question, if you could improve the two major existing surveillance systems at the national and local level, which are NHANES and the Youth Survey, what recommendations would you have for improving them that would have a meaningful or useful impact for your community? Lisa, you want to start with that?
Well, yes, thank you. That's pretty simple for us. It's be oversampling of Native Americans. We just don't have that. It doesn't exist. And then dollars at the local level for us to have feet on the ground and encourage the schools that are selected in that sample to actually participate so we can have weighted data. And for that's particularly what would be important for us is oversampling. And by tribe, understanding that you collect that information as well, not just Native American, American Indian, but you collect the information by tribe.
The End-Usersl and the Use Risk, Behavior Risk Surveillance Survey, I mean, these are great things, but I think that we ought to go back to something called, when I was in School of Public Health the first time, there was a book we read called The Health of Region Bill. And that was tied to a particular city in New York, but it taught a lot about understanding community health and the dynamics of community health. But I would think that we would recommend that there be, that's unidentified, perhaps 15 region bills. You have a national sample, you have state samples, but there also be appropriate community that were stratified by size and complexity and region. And that they be, and this would probably double the sample, well, might triple it to some degree, but something that can give a sense of what happens at the local level, and that you can apply assessments of interventions as they go along. But this would be 5 to 10 year longitudinal studies of distinct communities that could be anonymized as the individuals are anonymized in a national sample survey.
Thank you. Paul?
Without additional resources, I wouldn't want them to do anything different. I think actually, given their objectives, they do a fabulous job. They're, I think, two great surveillance systems at the national level. If they had a little bit of extra resources, I think I would urge them to oversample some special populations in just as Lisa's talked about. In LA County, we have a large American Indian population, and we don't have good data on that population. And then the other key population is the Pacific Islander population, which often gets lumped in with Asian, and it really makes this community angry, and I don't blame them, because their profile is at the opposite extreme of what the Asian profile is, and they feel like their needs are being completely obscured. So I think to have enough data to really look at that population separately would be important.
But I agree. Without additional resources, let me start there. I can only think of two things I would want them to think about doing, which one is, in addition to the releases that they do, to actually release non-statistical data at a regional level, whether it's the quadrants of the United States or what, just to highlight the potential variation and uncertainty that a national estimate has. Now, they might not want to do that in the front page press release, but somewhere that ought to come out in the data so that for interpretation in real time, somebody could say, but here in the South or here in Cherokee Nation or here wherever we've got some variation that we don't have sample size to be confident in, but it's not all homogeneous across the United States. In combination or maybe in substitution for that release to actually capture what we know from other data sources at a local level, so what the Behavioral Risk Factor Surveillance Survey says the variation is across, somehow that national release is an invaluable national point-in-time estimate of the risk for the nation, but the homogenization of the variation across populations or regions does a disservice to local efforts because it undermines the commitment that's trying to be built at those locales that need the help the most.
Thank you all very much. Now we'll turn it open to the committee members to ask questions.